We're good to go.
Great. Hi, everyone. Excited to see you all here. Hello. My name's MK Orsulak. I use she, her pronouns, and I'm a family medicine physician here in Sacramento and do work in a couple different spaces and brought here today based on my work with people living outside, people experiencing homelessness, and people who use drugs. So I believe in harm reduction and try to do that in my life and my values and also the way I practice medicine. And I'm going to talk a little bit today about some of the things we can do to improve access to some life-saving services like Narcan and low barrier buprenorphine.
Everyone, good morning. My name is Logan Hess. I'm the legislative director for Senator Susan Eggman. I am a Sac State grad, social worker. Very excited to be here. I'm going to be talking primarily about some of the state policy around some on syringe access programs, but I'm going to focus most on overdose prevention programs, which is something we have worked on for a number of years at the state level. And I know even longer folks at the local level in San Francisco and in LA. So very excited to be here and really appreciate you all joining and interested in this. And I didn't say I use he, him pronouns.
Great. So hopefully the goal is we have a lot of time together. So I think I'm going to talk for a little bit and Logan's going to talk for a little bit, but then we can kind of talk as a group with all these brilliant minds together to see how we can implement some of the strategies that we're talking about in whatever space we are in. So I'm just going to show one slide. This is not going to be a presentation. It's going to be one slide for y'all. So let me get that. Let's start. All right. Y'all, I have a tab problem. I got so many tabs open. Can everyone see this? Is everyone looking at the whole slide and not my presentation view? Okay. So a little bit about Narcan or naloxone. You know, medicine is complicated, and we research and study things all of the time to try to improve the quality of life of the people that we are caring for. And Narcan and / naloxone has been one of the most life-saving interventions that has not really been utilized to its potential. And I think there are a couple of reasons for that, but maybe here we'll start the interactiveness. Like, why do you think there are so many barriers to getting Narcan out into the community?
If I could, anyone on the call, if you don't mind, and I apologize for interrupting you, unless you have a question or speaking up, could you do me a favor and mute yourself? Thank you so much. My apologies. MK, back to you.
Oh yeah. So if anyone, you can type it in the chat if you don't want to unmute, or you can, if someone can monitor the chat while I'm screen sharing, because I can't quite see it.
Absolutely, we got you. So one question in the chat, or one comment, belief that if you provide it, there will be more use of the drugs.
Yes, which is not true.
One other one, misunderstandings of exactly what Narcan is and how it actually works. For example, it's not a mind-altering substance.
Yeah, great point.
And feel free to unmute and speak up if you want to participate or keep using the chat. One more, people don't know where or how to access it.
Exactly. And hopefully we can address some of those things today. And stigma, y'all. Like, people who use drugs are stigmatized, and some people, and this like hurts my heart to say out loud, like don't feel like their lives are worth saving. And that's something we need to really sit and think about. And I've heard someone say that to me before about why they don't believe in Narcan. So just to show you how effective Narcan is, here's my one slide. So this is a paper from 2013. So this is 8 years old now, that looks at fatal opioid overdose rates and related to how much Narcan is in the community. So the graph on the left is how much naloxone is in the world for every 100,000 people. And then on the right is the opioid overdose death rates. And so to start, if you have no Narcan in the community, we are doing a comparison here. So the opioid overdose death rate is 100% here. If you just get out 100 bottles of Narcan per 100,000 people, it decreases the opioid death rate by 27%, which is huge. If we had any other medical intervention that effective, it would be everywhere all the time, in my opinion. And even more shocking is if you just get 250 bottles of Narcan out for every 100,000 people, then it decreases the overdose death rate by 46%. So almost half. You could save almost the lives of people 50% of the time. And so this is just one thing I wanted to share to kind of start the conversation. And I'll stop sharing my screen. But we have this life-saving intervention. How can we get it out into the world more? I'll tell you there are a couple different ways that it's being done now. So in Sacramento specifically, you can get naloxone for free from the syringe exchange programs in town. The state of California has a program where if you work for a clinic, a nonprofit, you can order naloxone and distribute it. But I was talking to my colleague who is a family medicine physician who got surgery and was prescribed some opioids, and now there's a law that you have to have Narcan if you're prescribed opioids in California. And the copay for her naloxone was $40. And so we have, there are big pushes to make this available over the counter, which I think is exciting and a good way to move forward. Something that's been really, really a big focus is the risk of overdose rates when people are released from the prison industrial complex or jail. And is anyone familiar with this data? Like, what is the risk if you go to, let's just say jail, if you go to jail, and not even if you have a history of opioid use disorder. There's a study that looked at, from Washington, that looked at folks who went to jail and then their risk of death after they were released from jail. Does anyone have any idea about what the population of people who were recently released from prison or jail, what their mortality rate is compared to a general population? Any guesses? Yes, much higher. The data is like 10 to 25% increased mortality rate. And especially in that first week from releasing from jail, it is significantly higher. And we're not doing anything about it. We're not doing anything about it. There are some people who are doing some things, but as a whole, as a state, we can do a much better job. And this is like where advocacy efforts really need to come in, because we have the tools and we know what needs to be done. But right now it is not happening. One intervention, the bare minimum intervention, is to give people who are released from prison or jail naloxone when they walk out the door. And LA County, actually, shout out if there's anyone from LA here, raise your hand. Their county jail, if they have a naloxone vending machine in their release cell. So if you want it, you can just go up and then get it before you're released. And this has been shown to save lives time and time and time again. Yeah, Jennifer, I love the stoke. I love the stoke in the chat.
MK, I guess a barrier that I was just thinking of that I don't know that we mentioned, and I'm curious if your folks you've worked with have this experience, is people being afraid that if they provide Narcan or they're involved with somebody who's overdosing, they're afraid then to call for help because they don't want to get in trouble with law enforcement or something. I don't think in California that is allowed. I think that you're kind of given an exemption from criminal law, but is that an issue people are afraid of as well?
Yeah, of course. I mean, people who use drugs have been stigmatized by law enforcement since the beginning of this country, and it permeates everywhere. There are laws and protections against this. So the Good Samaritan law is a protection. If you call 911 after someone who has overdosed, then you are supposed to be protected. Similar to if you have syringes or sharps containers, that's supposed to be protected as well. But as we know, it can be interpreted many ways, and that's not always the case. Here, I'm gonna look at the chat. Let me see, I'm gonna pull you up. Great, so that is a perfect segue, Kelly, to what is Narcan? How does it work? There are there's three, but really two main forms of naloxone you can get around town. The main one that is used now is, I was like, why don't I have some downstairs? I should have brought it up here for me. Does anyone have a Narcan on them? Ooh, this is a great. Anyone have any naloxone? I know, okay. It looks like it is an intranasal is the main form. And it really kind of, I think there's a picture of it in this presentation that I have. And all you do is, here, let me share my screen real quick. So here you go. This is the Narcan box right here, and this is a little nasal spray. And it's 4 milligrams of naloxone. And if there's anyone who is, I encourage everyone to carry naloxone on them at all times. And part of the point and the main takeaways that I hope you bring from this is, like, try to get as much Narcan out into the world as you can. Because research has shown again and again, like I just showed you, like if everyone carried naloxone and if everyone learned CPR, we would all save more lives just carrying naloxone. And so it is an intranasal spray, and if there's anyone unconscious or not breathing, then you can try to give them naloxone. There's very limited negatives. Let me rephrase that. There's very limited medical side effects, but I mean, I'm sure you all have met people who are experiencing opioid withdrawal. When you give someone naloxone, it puts them into immediate withdrawal. So people feel awful. And just keep that in mind and be thoughtful. The National Harm Reduction Coalition just put out some, and then when Logan's talking, I'll put this resource in the chat. But they just put out a really great kind of pamphlet about how to talk to someone when they wake up from an overdose. Because sometimes it is just like negative and stigmatizing and mean, but really just like, hey, welcome back. I'm sorry you went through that. How can we help you feel better right now? So to answer your question, it is one intranasal spray. You don't prime it, you don't do anything with it, you just spray, and then almost, immediately, people will start breathing again.
I understand the nasal spray comes with 2 doses because there could be chances that the first dose doesn't work, right?
Absolutely, yeah. So one box of naloxone comes with 2 4 milligram nasal spray doses. And so you can give a spray, and if someone doesn't respond within 60 to 90 seconds, then you can give another spray. With some of the derivatives of opioids, for example, fentanyl, it sometimes may require higher doses or increased doses of naloxone. Great questions. Any other questions while we're here? There's a question in the chat about, is this only for people who overdose from opiates? And the answer is yes. So naloxone is an opioid blocker. And so the way it works is, if you use any kind of opiate, it binds to your receptors and releases endorphins and opioids, which kill pain and make you feel good. And but if you use too much, it stops you from breathing, which is why opioid overdoses are deadly. And Narcan or naloxone is a complete blocker, so it kicks all the opiates off the receptors and starts you from breathing again. This is to say, these days, because, and Logan, I'm sure hopefully we'll touch on this, we don't have like ways to test drugs. We don't there's not a good, everything is contaminated and there's so much variability. So sometimes some substances you might be thinking you're using a stimulant, but it might have some other kind of substance in it. So if anyone is unconscious, I think it is safe to try naloxone because you could save their life. Any other questions? So before we move forward, I'm gonna just break this up and say, so how do y'all have any ideas? So my two are we need to figure out in Sacramento, which is where I live, how can we do better to give people who are released from the jail access to naloxone? And then how can we do better to make sure that people who are discharged from the hospital have naloxone? So those are kind of two, I'll start us off there. What are some ideas in your community? How can we, who can we advocate to, or what areas can be changed? How can we increase access to this?
I would just say that I think a lot of times we see people who are, overdosing and openly using on the street. It is in, metropolitan areas or like downtown Sacramento, right? Downtown San Francisco. And so is there a way that we can encourage businesses also who are oftentimes some who are impacted by people using on the streets and have a lot of complaints about that, if they could be equipped to also intervene, because they probably are going to be seeing people kind of the most regularly, I think, the people in their community.
Absolutely.
So I'm in San Diego County, and at our clinic, we're a FQHC, and we also have a drug Medi-Cal outpatient program. So we have started prescribing or recommending Narcan to anybody who comes in with a stimulant opioid use disorder, regardless of whether they say they're currently using that or not. Just preemptively, as a clinic, we've decided to do that. And then for our MAP program, we also have a clean syringe exchange where we give Narcan, but at our intakes for our MAP program, we give them, our substance use disorder counselor initiates the request for Narcan, so that we're getting it out earlier than when the patient may get to see a provider. So that's two strategies that we're currently employing for Narcan.
Yeah, absolutely. Thanks, Katie.
Is that okay if I ask if there's any barriers that you've all encountered or that you all can speak to?
I know here for Imperial County, we're currently working on the grant from DHCS where we can get free Narcan. But our law enforcement, we come from a very conservative county, and law enforcement is scary to carry Narcan. They blame the heat because we have 120-degree heat, even though we explain heat will not mess with the Narcan. The Narcan will still be just as effective. Also, they're just very liability. They're all about liability. So I remember last year I was attending a conference where we received like a 30-minute Narcan training. It was super simple, super easy. And it was right before COVID hit. And we were going to work on coordinating this person that did the training at this conference to come down in Imperial County to see if we can initiate a training for our local law enforcement to get them comfortable with the Narcan. My husband works for a federal law enforcement. He was like, okay, I'll take it, I'll carry it. And actually federal law enforcement, Border Patrol, Customs, they do encounter, they're one of the first ones to respond, and they have no hesitation of carrying it. But for some reason, our local law enforcement have major hesitations.
Thanks for sharing. Has anyone from other spaces ran into this barrier or have any suggestions or solutions or effective strategies?
So one thing in the chat, with the syringe access site I work with, we provide free Narcan along with Narcan trainings with no questions asked. And as a result, actually engage with a number of people who access us after being referred by someone they know. And that's from Jennifer.
Yeah, definitely. Narcan for all.
I think just one kind of interaction between the Narcan access and state policy is it's like such a bipartisan issue. Like it is not it should not be a controversial issue. I know that there's some mention from some conservative areas, but there was a bill in the legislature a few years ago to increase access to Narcan in schools so that students could have access to it. And that was authored by somebody who became the Republican leader in the state assembly. And so I think though there is some like absolutely, and we'll talk about this with syringe access, very vocal local opposition to some of these things. I think at a state level, the policy goals are pretty clear and pretty supportive, but that is the challenge, is getting it into local governments and having them support these kind of things as well.
So a question from Michelle, that was my question, being a school counselor, should we or the SRO carry Narcan or both?
Yes, so I think that's in response to Valerie above. So how do you get access to Narcan? Do you have to be a doctor to prescribe? And then, so like you, it depends on where you live, but there most syringe exchanges or syringe access programs, you can get naloxone for free. You literally just walk up and ask for it. That's on it. That's where I get it because it's the easiest way. And I'm a physician. It's the easiest way to get it, and the cheapest way. It's free. And one of the barriers, this brings us exactly to one of the barriers, is that, yeah, you do, if you didn't have access that way, then the only way to get it would be for it to be prescribed by a physician. But there is movement in the world to try to get naloxone over the counter, so you can just go pick it up. And then I'm just going to read. So, and then, yes, I think definitely a school counselor and the SRO should have Narcan. And then Kelly's question is for Logan. Logan, do you know if that push to get Narcan in schools is also for students to be able to administer to parents who might have an opioid use disorder?
You know, I don't think so. I don't think that we have gotten into that realm of providing to kids for their parents, but I think that is definitely a strategy we should be talking about, kind of to answer MK's question from earlier, because we know, I mean, we've seen heartbreaking articles all over the news, and PR has done them, that we have a huge population of kids coming up whose parents are dying, and they're growing up, you know, in foster care with other family members because they're losing their parents, and part of that is so much due to this lack of access, to this stigma, and to not doing everything we can to provide people with the tools to keep them alive. So I don't think that was the focus of that bill. I think that probably would be a little bit more of a controversial conversation, but I absolutely think that we should be talking about it.
Can it get established for social workers to carry Narcan? For example, my friend is a social worker that works in Skid Row. Can social workers be given cases of Narcan so they can distribute it to their clients or people they encounter who may need Narcan? Great question. And I would recommend, again, and there's definitely many of these in LA, just reaching out to the closest syringe exchange and partnering with them. So you can sometimes, each syringe exchange does it a little bit differently. And you can partner to be a satellite to help with that, or they can come out with the social worker to provide access to naloxone. So that is the way that I do it in Sacramento, is usually partner with our syringe access program, and they'll come out and do provide unused syringes and naloxone. But definitely, and I would encourage you to reach out to your friend and let them know, because I think you could save many lives. So I think I just have one more minute, but I just want to say one last thing, and this is a whole topic in and of itself. But naloxone is the bare minimum. It is just saving people's lives, and it is a huge step. But really, we have to do so much work, and I can't wait to hear Logan talk about some of the next steps. But this is kind of like a stepped approach. So we have naloxone, which is just preventing overdoses, and step 2 is providing low barrier access to medications for opioid use disorder. And the 2 main ones are methadone and Suboxone/buprenorphine. And there's been, and shout out to Sierra Health Foundation, they're doing some work right now to try to increase access. And my work is working with syringe access programs to provide access to buprenorphine or Suboxone to people who are members of the syringe access program. And there are 1,000 things that can make it hard to get access to buprenorphine or Suboxone. And I just want to kind of leave y'all to think about this in the future and look in your communities and try to think, like, if you were trying to get access to this medicine, how easy would it be for you? Because you have to have Medi-Cal, you have to have transportation, you have to be able to get to a clinic, you have to be able to make the appointments. Some providers only prescribe it, like methadone, like once a day. Some providers will do, a week at a time. Some will do a month at a time. Sometimes you're required to do counseling. So there's, layer and layer and layer and layer of barriers to another life-saving medication. And yes, I hope you all can explore that and start thinking about ways to increase access to medications for opioid use disorder. And with that, I'll turn it over to Logan.
Thanks, MK. I will put up some slides eventually, but that they are focused on the overdose prevention program stuff. So I'm just going to start with some general state policy on syringe access programs. And so in general, the state of California has been very supportive of syringe access programs or needle exchange programs, or however you want to call them. And part of that is because there's such a long-term proven public health intervention to try and reduce the spread of infectious disease. And the state even, I think it was last year, maybe the year before, Assemblymember Phil Ting of San Francisco passed a bill that extended the provisions in law that allow for the furnishing of syringes without a prescription. Those in law, you're required to have a prescription. That's been waived for the last handful of years. That's been extended to 2026. But that bill went a little bit further in that it also reduced or eliminated some of the criminal penalties for other ways in which people try and access syringes. And so, for instance, if somebody tried to misrepresent who they were to try and get access to syringes, I think the main problem that we should be focused on, if that's the case, is why are they having to misrepresent themselves to get access to these, which are a proven public health intervention. And part of the problem that we have is with some local governments, and I'm sure you've all heard the term NIMBY, not in my backyard, people, and that is often used as a defamatory term, and I'm just using it for convenience here because there have been a few local governments that have been extremely resistant to syringe access programs. Top of mind is in Orange County. There was an Orange County needle exchange program, and they were attempting to expand a little bit to do some mobile sites where they were going to have 4 in different cities in the county. And they were challenged by the county and eventually lost the lawsuit. And the state did as well, because those programs were approved by the State Department of Public Health. And so that program is not operating anymore. So that's a program that is not operating anymore. There's been local resistance up in Humboldt there's the Humboldt Area Center for Harm Reduction that operates a syringe access program, and the city of Eureka has pretty forcefully asked to not have that service provided in their city. And so when the Department of Public Health re-upped their authorization for 2 more years, they were kind of specifically required to not operate in the city. So I think that syringe access programs have been around for a long time. We know that they work. Some of the arguments that people have against them are usually the really terrible, like, enabling argument, I think, that we hear with all different types of harm reduction, but more focused on needle litter. And so they'll say, we ended up seeing so many more needles in the community, which I think typically does not bear out with data. I think anecdotally people see needles and it's very frustrating, and people are scared that it's going to stick a kid in a park, and that would be a terrible outcome. But I think in general, the data over these programs does not really bear that out. And so that's kind of just the brief rundown I wanted to do on syringe access programs. And then I am going to share my screen just to talk a little bit more about overdose prevention programs. So if you haven't heard that name, that's okay, because that's a name that we kind of have just been using recently. If everybody can see this, let me know. These programs have been used for a long time, for decades across the world, never officially in the United States. And so you might have heard other names: overdose prevention programs, safe injection sites, supervised injection facilities, supervised consumption sites. And the really basic idea is kind of an extension of a syringe access program. It's we understand that people are using drugs. That is a reality. It would be great if people didn't, and it would be great if we can help folks in their lives, and to not feel like they are stigmatized for their behavior. But the reality is that people do use drugs, and I think as like policymakers, that's a reality that we have to live in. We can't pretend like it's not happening, like there aren't people using drugs on the streets, like there aren't people dying on the streets. And so these programs really are kind of the most basic, I think, harm reduction that we can offer, and that it provides someone a safe and sterile place to use drugs, and it provides them with the materials to do so. In general, these programs do not provide drugs. People will bring their own drugs with them. But I mean, there are some programs in Canada that are providing prescription drugs as well. But the idea is that you bring in what you have, and you can use it with clean materials, and you can use it in a place so that if you do overdose, someone will be there to intervene. As MK was talking about with the Narcan conversation, is this really, for the most part, opioid overdose is an oxygen problem. And so, overdoses can be reversed with Narcan. Somebody can be kept alive with CPR, with oxygen, but it does require intervention. So if you are alone, then you're very likely not going to survive that type of an overdose. So I just wanted to show you all what something like this would look like. We've had a few different attempts at these types of bills in the past in the state of California, and none have been successful. There's programs operating in Canada and Australia, across Europe, almost 100 facilities. And this is kind of what a model would look like in San Francisco. So San Francisco has been leading the charge on this for a number of years before the state got involved in trying to push some legislation. There's been some great community organizers and activists that have been pushing for this. And so a couple of years ago, they set up a model for what a program would look like. And so I think they called it Safer Inside. The city of San Francisco has been doing a ton of reporting, a ton of planning to be ready for this if the state is going to authorize it. And so this was kind of their setup for what it would look like. Sorry if it's a little bit blurry. This is not the highest quality image, but you can see that it's set up in different kind of booths with mirrors, with disposal equipment, and you can see like a chart there. The idea is that you'd have somebody there who could provide you with some instruction if you were doing something really dangerous, or you could have somebody there to intervene in case of an overdose. And I'm just going to chart a little bit for you the path that we've taken here in California. So we introduced our original bill on this in 2016, AB 2495, and everybody looked at us and said, "Are you crazy? Why are you trying to set up a bill for a place for people to use drugs?" And so that bill was never even heard in a policy committee. We did not get a hearing. And I think that was the first a lot of people in California had even heard of this type of an intervention. So in 2017, 2018, we did reintroduce a bill. Pretty early on, that bill went from a statewide to a multiple county pilot program that was time limited for a number of years. And so we did really determine we just wanted to show people that this would work since it's been successful so many other places for the last 30 years. And that bill, I think surprisingly to all of us, we went from not getting a vote in committee all the way to the governor's desk. And Governor Brown at the time vetoed the bill. And I think it looked at it in a bit of a narrow, as almost this was like the panacea that was going to save everybody in California from dying from an overdose. And that's not what this is. I think being realistic, this is just part of a continuum. This is one tool in the toolbox for addressing overdose death. And I think maybe the most important thing is you're really reaching the hardest to reach people. You know, I mean, if people have a home, in all likelihood, they're going to be using drugs in their home. If they're living in a car, in all likelihood, they're going to be using drugs in their car. But really, the primary people who use these facilities around the world are people who are houseless, people who are living on the streets, and that's kind of their only option is to use on the streets. And so you want to bring them in. Those are the hardest people to reach, the people that don't have connections with care providers, don't have the same connections with family. And so if we can get in the door, and this comes from, you know, my background in social work, is if we can start building that relationship and let people know that there are others out there who care about them and who want good things for them and want to make sure that they are alive, I think that's like the very first initial step you can take in engaging somebody in treatment. So that's the where we ended up in 2019, 2020, we had AB 362, which is essentially the same bill. That stalled when a lot of legislation stalled due to the coronavirus. And now we have another bill. So my boss, Senator Eggman, is not the lead author this time around because it's not in any of the areas she represents. And so Senator Wiener represents San Francisco. It made a lot more sense for a San Francisco member to author a San Francisco focused bill. And so that's where we're at. That bill hopefully will get heard in committee here in the next few months, and we'll move forward. So I think that is kind of just the most basic overview I can do of overdose prevention programs. We can talk more about like what the data shows the results have been, is they engage people in treatment. You're more likely to enter treatment if you are using an overdose prevention program than if you are not. That's data from Canada. They reduce public drug use, they reduce needle litter, they reduce crimes in the surrounding, they don't cause any increase in crime in the surrounding area. So there's a lot of really positive things that come from this. And I think the real only negatives that people have been able to identify are those same stigma-driven arguments about, you know, this is enabling and this is going to push people. I can't think of anybody I know or anybody I've met throughout the whole course of this that is going to decide, well, now there's an overdose prevention program, so I'm going to start injecting drugs. Like that just seems like such a ridiculous argument to me, but is one that's going to be made, I'm sure, by the law enforcement folks that oppose this bill. So I'll just pause right there and see if folks have some questions that we want to talk about, and if not, I do have some more, you know, overdose prevention stuff I can talk about.
While we wait for things to pop up in the chat, is there anything this group can do to support Senate Bill 57?
Yes. So that bill right now is in all likelihood going to be heard in the Senate Health Committee, probably in March. And so I'm a little bit more disconnected with that. My boss is a co-author, not the lead author this time around, but everybody around the state, I mean, you know, this is not, even though we've been working on this for a number of years and we had this bill that went to the governor, this is still a really controversial issue. We passed, when we did go to the governor, with the minimum of votes that we did, you know, we could in each chamber. And so I think if people are interested in this and believe in this and want to see this happen, one thing you can do is you can contact your local elected folks and say, this is something that we should have in our community to help. But then you can also contact your state representatives when it's going to come before them for a vote, and just let them know how you feel about it and why you think they should support it. And if nobody has any questions, I guess, does anybody, and you can be honest here, does anybody think this is just an absolutely bonkers idea that we should not be considering? Because even in my social work program, when I was an intern. So this was a bill I started working on as an intern in 2016. A lot of people looked at me and thought, what the hell are you talking about? This is really a step too far. And I think you end up having those conversations around data, number one, that prove that this is a good intervention. But then I think one thing that really struck me is we had a lot of conversations with people who use drugs, who came to support the bill, who came in to meet with us. And you realize that as the years have gone on, we've been doing this, the faces have changed because people are dying. People who come to the Capitol to advocate for this bill are dead now because they've overdosed and died. And one thing that they frequently said, and you see this in a lot of kind of reporting about this, is a quote, but I think it's absolutely true, is I think a lot of us want to have this goal that people can get in treatment and they can, turn their lives around and be their best selves. And the one thing that we all know is that dead people don't go into treatment. So we need to keep people alive. We need to show them that we care as a society. And I think that's the first thing we need to do if we really expect anybody to be able to engage in treatment and get well.
So from Kelly, Logan, you mentioned this is a bipartisan issue, but you found that when one party is in control, but have you found that when one party is in control of the House or Senate, these kinds of bills get farther along?
So I can speak only, to the California context. And so we do have a bicameral legislature with state Senate of 40 members and a state assembly of 80 members. And it is all population representative. And so each assembly member represents, about 500,000 people. Each senator represents about 1 million. The California government is, I think we all know, largely kind of dominated by Democrats at this point. There's super majorities in both chambers. That does not mean these bills are easy. Even then, we still had significant double-digit numbers of Democrats that voted against the bill. And when AB 186 passed its initial vote on the assembly floor, this would have been in 2017, we would not have passed with only Democratic votes. We did not have enough Democrats even to support the bill. And there were 2 Republicans, one from San Luis Obispo County, who supported the bill. I think they probably still had concerns and questions, but realized at that time that we needed to keep the conversation going. And so they voted to support the bill and move it along that year. And so I think the other tragic part about this conversation and getting the bills further along is every single year that this goes undone, you have more and more members who are personally affected, whose family and friends and community are racked with death from people overdosing and dying. The numbers are astronomical. I think we're going to be up over 80,000 dead from overdoses in the United States. And one thing I think, and I'm not a doctor and I'm not a chemist, so I think somebody correct me if this is incorrect, but in my research and my understanding of the drug supply we have in California is a lot of it is black tar heroin that's coming from Mexico versus the eastern United States is getting rock heroin from Asia. And part of the reason that we've been spared a little bit from some of the massive overdose numbers that we've seen elsewhere is because fentanyl is a lot easier to mix into the powdered form. But that's changing. I mean, we've seen some more tainted tar heroin with fentanyl in it in California as well. And so I think I am just afraid that we're going to start seeing more deadly overdoses as we're having more tainted drug supply here in California, which I think goes back to another thing NK said about testing and not knowing exactly what people are getting. I think as best we can, in addition to, getting out Narcan and hopefully overdose prevention programs, but give people access to test strips or, whatever technology. But, some of the technology is going to be really expensive and really hard to distribute. And so I think that is always going to be a concern is having, tainted drug supply that is very likely to kill people.
Yeah, which I guess kind of leads to, we're kind of on this tiered approach with naloxone and then medications for opioid use disorder and then overdose prevention sites. And then really decriminalization and legalization is, I think, the ultimate goal to strive towards. It has been shown to almost, the same concerns and stigma that Logan just mentioned about overdose prevention sites are always surrounding decriminalization and legalization. But again, in places where this has been done, like Portugal is the main example, it has led to, less crime, less HIV, less hepatitis C, less overdose, et cetera, et cetera, et cetera. So all the negative thoughts and stigma associated with these policies are often false and wrong.
And I think, Oregon had just passed by a proposition a decriminalization bill for a lot of substance use and possession for use. I don't think that touches on sale, which I think has kind of been a key policy differentiator, right? Is you still probably want to keep people from selling as much as possible, but like for people using, it's a public health problem. It is not, it should not be viewed as a criminal problem. It is a public health problem because when you're putting people in the criminal justice system for substance use, very likely they're not getting the treatment that they're going to need. And number two, you're having this problem that MK started with of people coming out of jail are much, much more likely to overdose and die. And so it's really just compounding the problem rather than trying to do anything to fix it and help people. And so that's, I think, where we really have to return to our base and think about, as policymakers, what are we trying to accomplish? And I think we want to help people. And there's going to be arguments on the other side that you're going to be able to, I guess, stop drugs from coming into the country. I mean, I think there's just some logistical questions around that. And so I think as a state, we really need to focus on what we can do to protect people's health and safety pragmatically in the world that we live in. Because if there was some, the magic wand question of if we could just say, yeah, drugs are not going to be a problem and everybody's going to be okay, that's one thing. But I think kind of criminally penalizing people out of our drug problem has not worked for decades and decades. So it's really well past time to be rethinking that.
I appreciate you guys talking about, and Logan, you mentioning this is a public health problem. We're moving away from the moral model of looking at addiction as a failure. And when you take into account health inequities and the inherent racial and bias that there is within these policies around having those people in our neighborhoods, I think that it requires a level of advocacy and involvement to, just like we've been talking about, to make this is everyone's problem. This is a public health issue rather than a moral failing, that if this person was just blank, then they wouldn't have this problem. So I appreciate you guys talking about that. Any other questions before we, Logan, I think you had one other piece, right? There's no other questions. Okay, no other questions in the chat.
Yeah, so I didn't really have much else. I just wanted to say that in the United States, we're well behind on a lot of this stuff. And as I mentioned, there's been almost 100, probably 100 sites operating. Some of them, as since the 80s, that have been providing overdose prevention services. And we do have one, at least one, in the United States that's been operating. We don't know where it is. We know that there's been research done and there's been articles published about it being broadly successful and matching the same levels of success that we've seen in other places. And so I think when we're taking like a pragmatic public policy approach, when we come to it, we always end up having to make these concessions in a way of like, we have this program that we know works. It works everywhere else. We have one that's operating illegally in the United States that is working. But even in the state of California, we have to do one that's, 5 counties for 4 years or whatever. And so it's like, you really need to bring people along slowly sometimes. And that you can understand, I guess, the reality of that. But I just hope that we don't all forget the people that are suffering in that time. I've in the many years that my boss presented this bill in committee and on the floor, I had to work with her on crafting her argument and her talking points. And one of the most tragic things that I don't think we ended up using, but I just wanted to make sure we were aware of, is how many more people have died in the state of California since we have failed to act on this. And not all of them would have been saved with an overdose prevention program. That's not the point, but it is the point to say we still have a lot of work to do. And if we can't take one of the most successful approaches at keeping people alive who are in some of the most dire circumstances in our society, we really need to pick it up. So I think that's kind of the closing pitch for me. But really happy to continue talking with folks. They can reach out. My information, Senator Susan Eggman, our contact information is on her website, her Senate website. So please feel free to reach out if you have other questions.
So is that okay if I add one piece while the group is thinking of any questions that they may have? What could be some action steps? And I can't help but think part of this really needs to be exactly what you're talking about, is really a grassroots advocacy and grabbing community partners and really doing that advocacy at the local level, and also maybe a day at the Capitol or something where the legislative body is hearing from us as constituents as to how important that is. So I wonder, just to the group or to the panelists, if that's if there are any action steps or that you can think of or recommend.
Yeah, so I think engaging with the legislature and talking with your own representatives is always going to be helpful. It's hard to organize days at the Capitol right now because of the Sacramento County COVID protocols and things like that. The building has seen a number of positive cases, and so one of the issue, I guess it's been a convenience really, is a lot of folks are doing meetings like this over Zoom, and so maybe that's more convenient, and folks from around the state can access your members more easily. But I think it is sometimes harder to engage with people in video. But that is one thing. And I think the other thing to keep in mind is there aren't a lot of like organizations or lobby groups that represent people who use drugs, right? Like there's a lot that work for other populations that people really feel for and care about, and also a lot of money, interest. But I think there's a lot of work that needs to be done to help organize a movement around supporting people who use drugs, because those lives matter. We've got people who are dying every day, and one of the core values that we have as an office is treating people with dignity and respect, and that's everybody. And so I really hope that there is going to be more of a local movement, because I think that is where we're going to have a lot of resistance, is local governments. When we did AB 186 and we limited it to a pilot program, there were some counties that it wasn't even a mandate, it was an option. They had the option of setting up a program if they wanted to, and they flew off the handle, saying that this is insane, we don't want to be a part of this. And it wasn't even a requirement. It was just something they could do if they decided to do it, and they wanted nothing to do with it. So I think a lot of pressure is going to have to come at the local level as well.
So I put Susan Eggman's website into the chat. I put Scott Weiner's website into the chat, because Senate bill, just so, and the way you can track that Senate bill is also in the chat. So you can look up the legislative, like there's a lookup, and so that's in the chat as well. Find your representative is also in the chat. Any other questions or comments? This is such an important issue, and I appreciate the both of you so much for bringing this topic, because it's so important that we get involved to really reduce the stigma. It really is. It's a stigma-related issue where it needs some attention, because the people who are dying really aren't, that are vulnerable, need some people to speak on their behalf. Any other final thoughts, MK, Logan? Any other final thoughts or words of wisdom for the group?
I was just going to leave with a challenge or a request. Well, one, to support Logan and the bill, and two, if you don't already have it, reach out to your local syringe exchange and get Narcan. Find the way to do it. So when you talk to people or patients or clients, you have that tool, and you can start to tell people how to get it and where to get it. And also so you can have it for yourself. And the easiest place to probably start is at the syringe exchange, syringe access program, working on my language.
I think I would just add, I think the data in San Francisco have shown that the overdose crisis has only gotten worse during the COVID-19 pandemic. And so there's been a lot of things that have kind of been put on the back burner to focus on the pandemic and the response, and rightfully so. I think this is something that cannot happen to, because the crisis around overdose was a an epidemic before the pandemic. And so I really hope that we focus on the things that have just been exacerbated by the pandemic, and we can't focus solely on COVID-19 when there are so many folks struggling, and whose risk has only grown. So that's the last thing is people who are, we know, most vulnerable coming into the pandemic are the people who've been impacted the most also. And that goes for basically any vulnerable population.
So I added some information in the chat for both the syringe exchange programs in California, the naloxone distribution project. If I'm missing anything, feel free to reach out. MK and Logan, thank you so much. I was wondering if it'd be okay if we had your contact in there. So I have Susan Eggman's office in there. That's one contact. And then in the chat is MK's information if you would like to reach out moving forward. And one last question from Katie: are all of the links going to be sent out after this break? We are recording, and the recording will also capture the chat. And so that will be shared with all the participants and put into our YouTube streaming channel. So we'll share that as well, so that you have access to all of this information afterwards as well. So yes, that'll all be shared. Yeah, so wonderful. Thank you all so much. So get a lunch break and then join us at the webinar for the listening lunch, so you can eat, and we'll talk a bit about mindfulness. I know many of you are multitasking, and then we'll resume with the afternoon sessions. But MK and Logan, I cannot thank you enough for your time in doing this. We really want to support the work that you're doing, and thank you. Thank you.
Thank you.
Thanks, y'all.
If y'all don't mind, turn on your video, do a quick wave.
Oh, if you want.
Thank you. Sarah.